So welcome everybody at the MGH brain-PBM clinic rounds. Today is September 23rd, 22. And it is my great pleasure today to welcome Lew Lim, CEO of V-Light, who is going to talk about treating acute COVID-19 with photobiomodulation clinical trial results and implications for the long haul. Lew, welcome and take it away.
Right. Thanks so much, Paulo, for inviting me. I'm going to share my screen right now. Right. I'm going to be covering quite a lot. I want to get started right away with our clinical trial that we completed actually about a year ago, and it's taken some time to clean data, analyze data, and all that kind of stuff. And we are actually we submitted to Health Canada for approval, and we're waiting. They, according to their normal guideline, they were supposed to have come back to us like 2 months ago. We're still waiting. Apparently they're busy, but here we go. What we're trying to do is to measure the time to recovery from respiratory symptoms. We use a particular set of questionnaires developed by University of Wisconsin. It's validated, 44 questions related to respiratory symptoms, and they developed it initially for pneumonia, for cold and stuff like that. But we thought it was among the most validated we could find to do a remote data collection study. So the primary endpoint is just a general, generally how sick do you feel today? Out of the 44 questions, it comes down to this, but of course, we have collected the answers for all these many endpoints. Number of days with two particular groups, up to 7 days and beyond. The statistical methods for everything. We use the Kaplan-Meier method. I'll cover it very briefly afterwards, and the Cox proportional hazard ratios, and they all to do with measuring the time to events, basically. Now we covered a number of secondary endpoints. Basically 43 questions were valid, and we covered the amount of time spent on mild symptoms, measured oxygen saturation, and reports on the adverse events. It's a lot of data. I won't want to cover everything, especially what we found in the adverse events, but I'll do it very briefly. We had, we interviewed, our protocol asked for 280 subjects. So we interviewed 701. 294 met the inclusion criteria, so they were there. After follow-up, we lost a number of people. We ended up with 267. And then this interesting things were happening because this is a home use treatment. We had to ship the device. It goes through shipping, training, and in the process, out of 267, people improved. So by the time we actually did a final analysis, we had 199 split between 100 and roughly half in active, half in under treatment, half in control. So 199, we reckon we get it at that number. I think the power was decent enough. Then we have a huge collection of Kaplan-Meier curves. If you're familiar with this, you're really measuring. It was originally developed for, to analyze recovering from survival from cancer. Now here we kind of flip it around and we looked at the probability of not recovering. So if your treatment is working, you should see the curve falling, and we assess over 30 days. below the control. Now, I want to be specific and say that we did not see a significance in everything, but in all the patients, but it was significant for those who exhibited 0 to 7 days of moderate to severe symptoms. At that time, when we did the clinical trial, the Delta variant was prevalent. It was everywhere. Today is a different story, but that's another story. So we found, in terms of time to recovery, we pretty much hit on the borderline significant 0.050 p-value. In terms of the hazard ratio, it was more or less there. So they are all supportive of each other. So we are trying to say that photobiomodulation, doing it this way that we do it, helps to accelerate the recovery. And we had a bunch of secondary endpoints too. But because of where I'm going to take us to, I want to highlight that the symptoms of headache, and particularly think clearly, and this is to do with brain fog, was where we want to take the past, says over 30 days. It was significant enough to point us to a direction from brain fog. I want to say it's not on the slide, but for tiredness, energy level, actually we didn't do too well. So we did not do too well in quite common symptoms of the lack of energy, but overall, in terms of measuring how sick people feel, we did pretty well. And I want to point to the brain fog. Now, those on photobiomodulation and active treatment, nobody was hospitalized, nobody died. In the control group, we had 4 hospitalizations, and one of the patients died. So we can suggest that it is helpful, but this is on small numbers. Now, how do we do it? What theories are we based on? We were fortunate that the device, we call it X Plus, was actually designed like 4 years ago. It was both intended to help to add to the neuro, to put one additional module to the back of the head to try to cover the visual cortex and the cerebellum. But the other thing that actually is originally developed for was to help with the immune system. It is one module that rests on the chest above the thymus gland. I'll show you. So we look at the phases of COVID-19 and see how we can try to see how it's going to help. The first stage is on the viruses enters through the nose as you breathe to the upper respiratory tract. Then it goes to these very, very stages. Now, there are interesting things happening in the nose. There's a microbiome. Those I see amoeba here. There is microbiome not just in your digestive system, but there's a colony in your nasal area too. So when you try photobiomodulation, you may increase the diversity. But there are more to this actually. Now, you are mostly familiar with the release dissociation of nitric oxide from the electron transport chain process in the mitochondria. Basically, the bacteria all have this. So you can do this, in theory, you can help release nitric oxide. And nitric oxide actually has been found to inhibit the progression of or replication of coronaviruses, and not specific to any particular variants or any strain. There was not a lot of work, but there was one done quite a number of years back, 15 years back, and look at what happens when the cells are exposed, the coronaviruses are exposed to nitric oxide. Here's a mock treatment. There's one with NAP that doesn't donate nitric oxide, and with SNAP, it's a long name, is a penicillin derivative. It actually reduces the count of coronaviruses. You are probably familiar now with the self-recirculating mitochondria. They are present in the nasal tract. And this, again, they may contribute to the release of nitric oxide to inhibit coronaviruses if you the right rate on your infrared light. And you can argue this also has a systemic effect because it is part of the circulatory system. This is a study that was done quite a number of years back, a long year back, with somebody I used to know pretty well, Tim Liu from China. And I'm sure there are more literature in the Chinese language. I just, this was something his group published that was kind of translated in English. But the bottom line was, and they were also looking at bird flu and the various SARS viruses as well. But what it is saying is that the presence of light from UV to IR actually weakens the envelope of the coronaviruses. So there's another. Sorry. Okay, I'm just going to carry on. Now, summarize the intranasal photobiomodulation effect increases diversity of the microbiome colony in the nasal cavity, releases nitric oxide from the microbiome. There's systemic effect and there's weakening of the coronavirus envelope. I want to, there's a lot to talk about actually, systemic effects, cytokine storm, and a bunch of other things as it gets down to the lower respiratory tract. This is where the Delta variant was actually fatal. The Omicron today are really pretty much up to, in the upper respiratory tract. That's why they don't have so much trouble with the Omicron variant today. But I just want to quickly touch on why this was, hypothetically working with the way if you direct light to, the sternum and the thymus area. Now the damage to the endothelial cells in the pulmonary system, even to the heart, is significant in the height of the pandemic. You can say that in early stage, the virus get attached to the ACE2 components, and then it moves on to progressively move deeper and creates symptoms of pneumonia. But it gets more significant to quite a lot of people after day 7 because it starts getting into the endothelial cells and thus causes this damage. And I will touch briefly on how it gets more systemic and visceral, attacking multi-organs. Now, so what do we do? Photobiomodulation, you all recognize, it goes through the electron transport chain. It does these transcription factors that accelerate wound healing. It's been covered quite extensively, I think, in discussions about accelerated healing, and these are examples of diabetic wounds responding. So accelerated wound healing is one of the outcomes we're trying to reach. Here is positioned here. There are 3 paths that we're hitting. One is to the bone marrow, then to reach the thymus gland and to the lung with near infrared. I wouldn't know exactly how much of the energy actually reach the lung, but there is evidence to show that it can. And that was, I don't have the sites here, but there were some published studies for the biomodulation in the clinic for severe cases, directing lasers to the lungs, and the patients were responding. Not a lot of work is done on photobiomodulation and what it does to the thymus, but there were discussion. Here is one that is, this hypothetical outcomes to do with the extra pineal melatonin. I think this is very interesting. It's something that I wanted to follow up on to affect sleep. But The suggested mechanisms, again, on the normal respiratory chain study, bone marrow, you mobilize the mast cells, it goes and differentiate. Actually, it gets mature in the thymus gland. So here is a theory that we go by. But nitric oxide is being in discussion in COVID-19. Discussion and seeing if we can find a treatment for the infection. And here is a suggestion that why don't you breathe nitric oxide? It has this actions being antivirus. It does all these other things, and there is also some discussion about reducing the inflammatory factors as well. So it gets deeper down, and now we're starting to hit on to inflammatory issues and attacking the other organs, creating the cytokine storm. So the inflammation is going to start to look really important here, because the cytokine storm is really about, it speaks for itself, the uncontrolled activity of the body to try to resolve this. And there's some early studies, but here's one. Actually, we've always talked about effect on inflammation for years, but these, studies have not been very clear. These animal studies, cell culture study. Here's one that shows significant decrease in the IL-1P, which is one of the prominent inflammatory factors. And I don't know if any one of you co-authors were here. This was just literally published early this week. I was one of the editors. I think that was Australian and Libby, one of the editors too. Now, this study was, I think it's very good because it does a review of what's being done, and it just missed the mark by something quite important. It covered literature up to June 2022. So when I was editing, I thought the authors should emphasize that they were all animal studies at best. And they actually missed this study that was published in July 2022. And I think for me, doing this work in COVID and photobiomodulation, this is actually a very, very important study for me. It's done in Iran. They had 52 subjects, double-blind, placebo-controlled, they call it a pilot study, but it looked at some key inflammatory cytokines. These are the bad boys, the IL-6, kind of is anti-inflammatory. So everything was kind of reduced with photobiomodulation. They shown lasers to basically the pulmonary areas from the back. And what they also did was, okay, this is the good cytokine, this is the bad, these are the bad ones. Look at the ratios and see how they compare. Actually, the ratio between IL-6 and IL-10 over time were reduced. So photobiomodulation is kind of also actually improved the ratio between the good and the bad cytokines. So that was really good. I was really hoping to see a human study, and here we go. So in summary, the effect on the sternum thymus and the lung, it accelerates endothelial healing, the stem cells synthesis migrating, basically the mast cells that are migrating to the thymus for maturation into T cells, nitric oxide downregulating these acute respiratory distress syndrome, ARDS, common with COVID-19 at the time. controlling the inflammatory markers and nitric oxide to inhibit pro-inflammatory cytokines. So there we go. We have good data to support photobiomodulation for acute COVID-19 infection. But today, I think there's less interest now. The masks are off. You can join the parties. Unless you're in the plane, you're basically mask free, and people are less worried. And President Biden declared that the U.S. is COVID-19 free, whether you believe it or not. But there is the sentiment today. Now the worry now is on long COVID. There are millions of people out there who are still suffering from long COVID, and I come across personal people I know who have it. So we see how we can progress to long COVID. I'm going to spend a bit more time here. So now we need new data and new intervention parameters. The CDC has published on the website. There are actually 200 over symptoms out there for long COVID, and these are the main ones. And the ones that you often hear and read about is tiredness and fatigue, interfering with your daily life as symptoms get worse. This post-exertional malaise is very real. Whether it's physical or mental, you get tired. There is the ongoing low-grade fever. Then there is, here's what they always reporting: shortness of breath, coughing, chest pain. This is tachycardia, fast beating of the heart. There is brain fog, which I want to move on to and why we do it. There's headache, which we also found improvement in our earlier study. There's sleep problem, dizziness, there's other things, pins and needles, and anosmia, dysnosmia, and so on. Depression, the mental aspect, diarrhea, stomach pain, muscle pain, and so on. Now, a lot of patients are complaining that they are getting gaslighting. They use the word gaslighting from their physicians, in saying that, at least in the earlier days, it's in your mind, you are tired because you're stressed. You're just recovering, so you're going through all this stuff, and a lot of the vital signs and feeling your doctor examination are not showing anything. Routine blood test, chest X-ray, ECG, it seems normal, and the symptoms are very familiar with something that is a puzzle for the medical communities: the ME or CSF, chronic fatigue syndrome. Actually, in Canada, there is a Schedule A of medical conditions, and this is not actually listed because people don't really understand chronic fatigue, but it is prominent in long COVID. So it's understood by healthcare providers, and so on. But the government is recognizing this. There's too much going on, and the NIH has launched with funding from this present government in the US to really try to understand it. There's 1.15 billion in funding that was, I think, released last year. I last read that they are targeting 40,000 recruits. And at this time, they want to do that at the end of this year. They've got 8,500 now. So there's quite a lot of work that's ongoing. It involves many research institutions. But I say that long COVID is real. I actually interrupted my preparation for this presentation yesterday. There was a meeting with long COVID patients. I spent 2 hours listening to them. They're actually in Canada. And many of them are actually advocacy groups that are patients research kind of advocacy groups. Some are research in the universities. A couple of them are medical doctors themselves. So it's very real. it's heart-wrenching, to listen to people with suicidal ideation because they're totally incapacitated. There was one lady, I'm in Toronto, so I'm on Eastern time, and she's from Calgary. And we had 4 o'clock, and she was 1 o'clock, and she was just, she was one of those who were slaughtered to share her testimony. And at that time, we were literally watching her crashing mentally. And during her sharing, she was like, kind of, okay, I'm losing it. I'm trying to put it together and try to share this with you. And there was also a professor at the university. I'm going to share what she's trying to do pretty soon. She has, she's for real. She's not functioning as not anywhere near what she was, but they're all still trying to work and try to make a living. So there's a lot more to say, but it's heart-wrenching. But the long COVID conditions is not the same as acute. The symptoms are pretty different, right? And you don't see viral load. There's no, antibodies are not really working on them. But we learned a few things. Like I said, we did not see positive outcome for, and when I say fatigue here, it's physical fatigue. But we saw mental clarity and headache improvements that lead us to how we want to solve it. So let's pick apart. Let's not try to do everything, investigate everything. We are not sure whether it's going to help with energy levels and fatigue, but brain fog, actually, there were about, I think we had like 13 or 15 people sharing yesterday. Everybody had brain fog. It says, long COVID, 32% brain fog, and there's the other major neurological and psychiatric symptoms up here, like memory, and this is actually mental fatigue, which we want to cover, but for certain reasons you have to compromise on what you want to do to investigate. And looking at the presentations for cognitive functions that are affected, you can say, yeah, brain fog is almost all of it. And these other things like poor attention, difficulty thinking, difficulty executive functioning, and so on. I think they're all related to brain fog. Just use a word called brain fog, No, brain fog is not necessarily all that's just happening within the brain. It is a multi-system effect that involves, the whole body virtually. Here's a bunch of things, your various systems, central nervous system. But if you look at the literature, this is a review. There's cerebral hypoxia. There is thrombotic state. There is this blocking your circulatory artery. And then there is various other markers and so on. And then there's discussion about direct viral infection in your brain. I'll cover that. That leads to brain fog. So it's a complicated thing, right? Can we treat brain fog with photobiomodulation? Now I'll go back again. Okay, let's pick a path. We saw things clearly. Let's try and go along this path and see how it's going to work. But there is a number of theories on regarding brain infection, long haul inflammation, and I will discuss more about inflammation, as I alluded to earlier, being a key factor in brain fog. This is a discussion paper. It could be now there was this, I remember quite clearly, maybe a year and a half, towards the end of 2020, when they did autopsy on patients who died from COVID-19. And it was not a lot. Actually, there were just a few people that seemed to have traces of the SARS-CoV-2 virus in the brain, but they were present. And so here's a theory: could have gone through the nasal route through through the mucosa and to the past the cribriform plate and so on. It could be from the infection in going via the vasculature system to your brain, because the brain receives blood circulation. It passes through the blood-brain barrier. And this is a discussion about also getting into the cerebral spinal fluid through the choroid plexus. A lot of this work was done at Stanford. There is, they even, I'll cover that to a Stanford group arguing, this is causing actually the response from your immune system causes this inflammatory manifestation. So there is the long haul looking like actually is coming from inflammation. It could be a side effect of cardiorespiratory distress and COVID-induced multi-organ failure, particularly if those have gone through really, in under intensive care, very, very severe care phases. There's overactive immune system. We are starting to, touch on autoimmunity here for long-term effects. There's inflammation of the meningeal cells that could increase fluid leakage, activating macrophages, microglia for further brain inflammation. And this is getting to develop into or starting to look like an autoimmune issue. The olfactory bulk layer, in the literature, in review, olfactory deficit increases the likelihood of brain fog in long COVID. So there's quite a lot of link between your olfactory dysfunctioning in the brain. And here, there's some illustrations to show how it's affecting even the hippocampus. Actually, there is direct channel between the olfactory bulb and the limbic system, hippocampus, actually didn't show the thalamus and the amygdala. But there is it's going to be what affects is quite likely to affect quite a large area of your brain. There are more literature that covers if you have smell alterations over 6 months, you're likely to have cognitive impairment, and you can for sure that you can even measure it. So the olfactory area is pretty important. This is a this shows a lot, but actually this was more like a literature review that was done and tried to look at how you're getting brain fog, and identifying the various mast cells that from here that became all these pro-inflammatory factors, and activating the microglia, leading it to more of it. You get long COVID syndrome that looks like the chemo brain. And if you do some work looking into chemo brain, it seems to point towards the inflammation that's caused by chemotherapy. Now, what this group is trying to say is proposing a treatment, and this was actually more discussion. They haven't done the clinical trial to show this. So if you introduce Lew Lim, which is a flavonoid, flavonoid has been found to actually reduce inflammation. You do this, and you may be able to reduce the inflammation in your brain. So, and then it helps with hypothalamus and the other system in your body too. So there are the discussion. People are thinking about how do we try to address it. This is one way. They encapsulate luteolin into some liposomic components in, I think, a component of the olive oil from the pulp to try and be a carry to the brain to try and treat it. So that's all very interesting. But I was looking for imaging. I thought this was actually just on two. It's a Dutch study on two patients. Now this is a PET study. They had a tracer that relates directly to inflammation. It goes by this code in the vertical axis. And what they found was, okay, here they established the parent fraction here, but they found they compared the two patients, the red and the dark blue, and compared against healthy control, even compared against patients with multiple sclerosis. What they found was in the PET imaging with the tracer, they actually, the inflammation was the imaging showed, but up to 121% and 76%. It is widespread. They were pointing towards other studies earlier without this particular imaging, and where inflammation was found, mainly in the olfactory bulbs, medulla, brainstem, and the cerebellum. Like I say, it's all over. This is another study, and we're starting to see how it is relating to dementia and Alzheimer's disease. This was a great study that is complicated. You've got to be familiar with CRISPR techniques and multimodal omics in order and all the various things in computer modeling. But what is found that the neuroinflammation and microvascular injury, they are actually common factors between COVID and Alzheimer. Actually, they're also teaching us here on the what's underlying Alzheimer's, and that is possibly to do with inflammation and microvascular injury. It's not just resting total in your brain. It's not just beta amyloid and tau, but they do find, I think they're looking at 450 subjects or something, quite a lot. 80 biomarkers, and if you're familiar with Alzheimer's disease, you're prone to it. You have APOE4 allele. The more copies you have, the more it is, and it actually reduced the allele actually reduced the defense against the viruses. So we're starting to see common factors. And now the more linkage with brain fog and Alzheimer's disease. This is more of a perspective from biochemists. The SARS virus introduces inflammasomes like TGF-beta, and what it does is actually it weakens the ryanodine, which is actually what it does is a leakage here, and the release of this RY-R channels, which actually this leakage actually what happens here is it increases the calcium ion activity. So you overload the mitochondria, ROS, and go on and so on. And then there is a reduction in calvindine, which is kind of a neutralizing factor. So what happens is when the biochemists discuss ryanodine, it's often applied to cardiac dysfunction, pulmonary, but actually is also applicable to brain fog, cognitive behavior, tau, and so on. So you have, and they found actually increased phosphorylated tau, which is a prominent factor in Alzheimer's disease. So there is more neuroinflammation, the cytokines, those gain activating of microglia. What it does is, here's the common thing here is the increase of phosphorylated tau in the cortex and the cerebellum. So we're seeing more commonality between that and Alzheimer's disease. So those who are following Alzheimer's disease know that there's quite a lot of uproar when Biogen released this drug, Aduhelm, because it actually reduced the biomarker of beta amyloid. The theory was beta amyloid, reduce that, and you're going to have the Alzheimer's disease. More controversies later when they found that the earlier kind of foundational study that came out of Minnesota was saying that the data were actually doctored. But anyway, I think it all came to a screeching halt when I think January, when it was reported that one of the patients, a Canadian woman, died of brain swelling. This was already reported earlier that drug causes brain swelling, but somebody died in that study, and that drug was a failure. And I think FDA, although they gave them emergency use authorization, they pulled out of the study because FDA really restricted them only to clinical trials. That is a story now. The research into Alzheimer's is starting to move away from beta amyloid and looking at other factors. And this is a work that's driven by a group actually in Canada between University of Toronto and Dalhousie in Halifax, suggesting that, this is really a autoimmune problem. It is not just beta amyloid. The interaction between the immune activity and beta amyloid could be just a presentation of what's going on. It could be an immune effect, and I'm saying this because now we're seeing similarities, and saying that if photobiomodulation can possibly treat Alzheimer's disease and dementia, maybe we can possibly treat long COVID brain fog. What they're suggesting, okay, let's go find a treatment for it, and they are suggesting the introduction of tryptophan metabolite. In the animal study, they actually found a reduction of, okay, you do this, what tryptophan metabolites does, it is actually reduces the inflammatory factors. So we do that, and then the result is the reduction of these markers of beta amyloid is shown here in the animal study too. So now this is literally actually when I talked about, I spent 2 hours, actually listening to long COVID. One of them was this researcher, Manani Mukherjee from McMaster University. And literally, this paper was published yesterday. She didn't talk about it, but I just found it this morning. And I thought it's a good time to put it here. And what they found was, as an indication that this is autoimmune, looking at 106 patients, they measured ENA, anti-nuclear extractable nuclear antibodies. They are around for over a year. They did over a year long study, and there were the presence of TNF alpha and these other markers, D-dimer, IL-1B, CRP. They're all around for a year. And she actually shared experience. I got COVID. I did everything. I got COVID. Now I have long COVID, and she's the one that I said experienced brain fog, and she's not functioning mentally anywhere near as she did before. So long COVID is going to be recognized as an autoimmune disease. I think Alzheimer's disease is also going to be recognized as an autoimmune disease as well, progressively. It's going to be a re-steering of this big, like, Titanic is going to take a very long time, but I think slowly people are starting to go into that direction. I go back to the review study, I mentioned it before. That shows that,
Just to let you know that we have less than 10 minutes.
okay, I'm about done soon. That shows that photobiomodulation has a positive effect on inflammation. And I go back to this particular study and show that photobiomodulation actually does reduce inflammation in COVID-19 patients. There were other imaging done. There's one on somebody healthy, and you see atrophy in the the cerebellar area, the spaces in the hippocampal area, and the basal ganglia. So there's atrophy involved too. Now, when I think atrophy, I think of I think Linda is here. We did this investigation a lot with your work, and you found gray matter volume increases. So there's neurogenesis in the thalamus and the hippocampal area. So photobiomodulation could have an effect. Then I looked at the study and I pointed this is Linda Chow's work on using gamma photobiomodulation 40 Hertz on dementia patients and get all this. So it shows on fMRI as well. I think Marvin co-published a paper maybe last year too on use of photobiomodulation on dementia and Alzheimer's. There is and then now we're starting to progress towards a lymphatic system, and the choroid plexus is the what's between the CSF and the circulatory system. Now that is being affected by COVID-19. So it has a long-term effect due to inflammation. Now, here's another proposed treatment is talking about lymphatic, and this group say, okay, if you try to drain a lymphatic, do a lymphatic drainage, you see positive effect. They actually did this technique, lymphatic drainage, and found the improvements 41% for men and 60% for women. It is out there. It's not normally in the among physicians. So there was some work and discussion. I see some of the authors are here talking about lymphatic photobiomodulations. Now we can link all this together. And if we try to direct irradiation to here, which is the lymphatic vessel, and also here, which is a junction for this circulation of the CSF, perhaps we can actually improve it. Now I want to summarize we covered neuroinflammation, parallels between common brain and Alzheimer's disease. We can control inflammatory factors with photobiomodulation. The markers of Alzheimer's, phosphorylated tau in cortex and cerebellum. We can, I didn't say much here, 40 Hertz gamma actually was shown by MIT in 2017 to activate the M2 microglia to remove these deposits. The olfactory hippocampal disruption, and there is the restoration of olfactory hippocampal functions with intranasal PBM. Widespread cortical cerebellar degeneration. We have seen possibly regeneration of brain cells. Resistance in lymphatic drainage, introduce photobiomodulation to the lymphatic system. So we could point one here. This is going to be the basis of our next study, long COVID. Here to do the usual thing we do for Alzheimer's disease, and one extra one here to help to help with lymphatic drainage here and here. So it's going to be a double-blind, randomized control study. It's going to be real-world home use, and there'll be remote data collection. So we want to improve our chances because we have evidence. And that evidence from related study, we have improved actually the usability of the device. And now what this is important because our earlier study did not have a sham. It was impossible to do a sham when you have one that points to the chest and the intranasal is visible red. But we have developed now, we have used a earlier version in our existing study, but we're doing a new one that is even better, I think, with a sham device. And we're going to do a 2-stage pilot in a pivotal. We're looking at various measures. This is one we're looking at, Cambridge Brain Sciences. For short-term memory, they found actually they can measure brain fog, patients with brain fog with their own measures. With short-term memory, reasoning, verbal processing speed overall. So they're pretty significant. Processing speed is identified with brain fog. So coming to the end, we are more or less ready with the synopsis of the protocol, right? But we are looking for co-investigators for sites, recruitment resources. The study is going to be more US-centric than it is Canadian. So I'm putting out there, if you yourself, anybody, I see Jeff Knight, he is actually, we have quite extensive discussion with Jeff Knight and Margaret Nazel and possibly using Boston as an investigational site, but we're looking for more. So I want to thank all these who are involved in the acute study. You can contact me. And thank you, everybody.
Thank you, Lew. This is a really exhaustive presentation. I'm suggesting here that we might have a follow-up time where you could present just even briefly your study. You said you have a more kind of a synopsis potentially. And
you can remove me from share slide?
Sure.
So we can see everybody.
David, if you don't mind. And we could also have a discussion over the data that you presented. I think there are many questions here. Maybe we have time for 1 or 2 1-minute questions, and then if you're okay, we can schedule another time to present your study to the entire group and for more in-depth discussion on the topic. Anyone wants to go first? Or? Well, if no one has a question right now, I do have one question that might require more time, but I wonder, with the experience that you have, if we had a patient walking in our office with either, acute COVID, probably it's unlikely, but long COVID, what do you think would be the treatment that we should offer them? What are some parameters or some characteristics of the treatment with PBM that you think it's advisable?
Yeah, I would do what I want to do for the long COVID study, to use the same device as we do for Alzheimer's disease, to pause at 40 hertz, to, we point to the default mode network. That's, I see we've added one to the pack to actually to enhance the effect of the intranasal around another lymphatic junction at the back. But what we are not adding to the clinical study is just because we want it to be a sham-controlled double-blind study. So I would, because there's evidence to show that your long COVID is still to do with the lingering effect, the damage to your endothelial cells in your pulmonary system. It hasn't fully recovered. The inflammatory response to the COVID infection is still there. It's becoming chronic. So I think if it's not in a clinical trial, I would still add one to the chest to actually add to the effect of photobiomodulation. That's how I would do it. I've try to see if there are better ways of doing it. I haven't figured it out yet, but I think there's a pretty good chance just because we see, good results from our acute study. If we follow that path, we may have a good chance of succeeding for long COVID. I actually have anecdotal reports of people. First of all, among my staff, everybody else, no one's, they have got, a couple of them have got COVID, but no one's got long COVID, like the kind of intensity that I'm hearing from other people. And when they use it, like intranasal, we seem to be able to avoid it. And I got anecdotal reports that people with long COVID symptoms seem to, they seem to respond better. They seem to get out of it with the gamma on the head.
Okay. Well, thank you so much, and to be continued. So we'll reach out to you and see if you have any other available time to discuss more. Thank you all for coming today, and let us know if you have topics or if you yourself want to present your data or any clinical cases. Reach out as we are forming the schedule for this upcoming season. Thank you. Take care all.
Thanks, everybody.
Thanks, Paul.
Have a good weekend.